I call it from the bottom of her heart. You see in the bottom of the picture there, our hospital, it's Rabin Medical Center. We're working here. On the right hand, it's our cancer center, Davido Cancer Center. I'm working here, and my oncology fellows are here. So the presentation was prepared by my fellow Amos Levy, and we're speaking about the patient, a 63-year-old female. She is married, +4, resides in northern Israel. Until recently worked as a kindergarten teacher assistant. She is physically active, and she was active. She is actually active smoker, 25 pack year, menopause, G7, P4. After femoral DVT a few years ago, following leg casting, she completed anticoagulant therapy. It was a few years ago. So at the beginning of this year, on your holidays, and Christmas holidays, the patient developed mild dry cough for the past 3 weeks, without fever, without wheezing, night sweat or weight loss, or any changes in her bowel movements. She had progressive effort dyspnea for the past 2 weeks, denies PND or autopnea, rest dyspnea, pedal, or any facial edema. She denied recent flight or immobilization, or any chest pain or palpitations too. Actually, on physical examination, she was quite stable with mild dyspnea, respiratory rate about 18, with low normal blood pressure, 107/70, and she was tachycardic, heart rate 108. She had soft abdomen, no lymphadenopathy, jugular veins were not distending, and she had regular distant S1, S2 without murmurs or gallop, and no pedal edema. You see her first blood count. She's a little bit anemic, hemoglobin 11, and glucose is normal kidney function, but she has elevated LDH. Gamma GT is 3 times upper normal limit, and the ALP is elevated too. She had normal other tests, including normal white blood cells and platelets too. So at this time, the chest X-ray was made. Anybody wants to describe this chest X-ray?
Certainly looks like an enlarged cardiac silhouette, and the left bronchus looks a little bit splayed. So I'd say probably left atrial and left ventricular enlargement. I can't tell from the projection whether there's any kind of infiltrate or not.
Any pericardial effusion may be in differential diagnosis here, no?
Yeah, sure.
Okay. So the next thing, ECG was done. What you see here, it's tachycardia, sinus tachycardia with non-specific STD changes. Any other things somebody want to mention? Okay, so the patient actually was quite stable at this stage with some tachycardia, and we have to do some examination, and this is the echo that was done in northern Israel. So at the time that any of the fellows to explain what we see here. It's very impressive. Anybody wants to describe the findings?
Good morning. Looks like a parasternal long axis view, and you can see that there is some fullness, maybe in echo density in the right ventricle, at least involving the right heart. Okay. Maybe a small pericardial or trivial pericardial effusion you can't really see completely in this view.
Mm-hmm. Okay, so next view.
Was the proximal aorta, was that just an artifact? It looked like there was...
It's an artifact. Yeah. So you see it's a short axis view again. Again, the same space-occupying lesion. It involves right ventricular wall, and partially obliterates right ventricular cavity.
Yes.
So in this view, we see right ventricular outflow tract is already obstructed by this space-occupied lesion. You see short axis of aortic valve. And it's four-chamber view with slightly more than mild pericardial effusion. It's mild to moderate pericardial effusion in my view. And a huge mass here. Any thoughts here? How we manage this patient at this point?
Well, this is certainly almost for sure a tumor. The question is which version, and whether it's metastatic or primary is sort of the essential question. Just the way that it appears, I'd probably say, because it looks like it's involving the whole RV wall, free wall.
Yes.
Whether that's a sarcoma or some sort of T-cell lymphoma.
Mm-hmm. Or maybe some metastasis from kidney or any other place.
Yeah, that doesn't usually go like that, but that would be a possibility. If it's renal cell cancer, usually you're going to see some sort of extension coming up from the IVC.
Mm-hmm. Another IVC was totally normal. It didn't show that.
Yeah, and then of course, anytime you see disease, tumorous involvement in the heart, you have to think about melanoma if that's in the patient's past history.
So we remember that the patient had previous pulmonary embolism 3 years ago. And actually the next thing that was done, it was done whole body CT. And first of all, you see the huge mass in her right ventricle. It's right ventricle.
There's a clue to the diagnosis that her LDH was pretty elevated, which is characteristic with lymphoma. So just because of that, I would probably put that at the top of the list.
Mm-hmm. So Professor Carver thinks about lymphoma in the first place?
That would be non-Hodgkin's lymphoma, Joe.
Well, the problem is it probably would be T-cell.
I don't think you can tell. Yeah, I mean, I don't think you can tell. So it's up there. I don't know. I wouldn't make a bet on anything, but I would bet non-Hodgkin's more likely than Hodgkin's.
Okay, so actually we see another very fascinating frames of this space-occupying lesion. You see that we have superior vena cava involvement here, even with some obstruction here, and a huge area of the right ventricle wall, including tricuspid ring and even part of the right atrium are involved in this process. And this is the coronary angiogram, CT coronary angiogram, and we see pretty well that we have actually the spearing of right coronary artery cause. Could anybody explain why this right coronary artery is so intact into the SOL?
So what are you saying there? That this little string is the lumen of the pulmonary artery?
Yes.
Lumen
is aorta. It's aorta, and it's a right coronary artery. It's intact.
Oh, okay. So the tumor is surrounding the right pulmonary artery.
Without invasion of right coronary artery. See that?
Yeah, that really sucks. Yeah, I mean, so then non-small cell lung cancer would probably be, or some sort of lung cancer would be the next to get that type of mediastinal disease.
Actually, at this point, we knew that nothing was found in any other regions, so everything was clear except the heart. So the space-occupying lesion was only in her heart, and it was the moment that the treating physicians felt that cardiac surgery may be needed here, and she was transferred to our hospital. It was the 1st of January this year, and this lady was transferred to our hospital, and she arrived in pretty good condition, but she was still tachycardic and a little bit desaturated, about 91% oxygen saturation in room air. And at this point, we had a differential diagnosis list, as was told by our faculty, about sarcoma, about metastasis from distant places, about lymphoma or Hodgkin or any other kind of lymphoma. And one of the things we have to think about myxoma, it may be benign primary, but it's too large and probably it's not the case, or metastatic from renal cell carcinoma, melanoma that was mentioned by them, or breast cancer metastasis, or from lung cancer, it may be sarcoma even, or any other kind of some very strange cancers of the heart. At this place, when we know that nothing was found in any other organs, so we're talking about primary cancer or primary tumor of the heart, and on the left side you see the list of the possibilities. It's myxoma, rhabdomyoma, fibroma, lymphoma, hemangioma, or cystic tumor of the ventricular node, or even paraganglioma. And from malignant causes, we have to think about sarcoma and lymphoma. So the first dilemma in this place was how to sample the tissue, because it's a huge mass, and the patient is a marginal patient in terms of hemodynamic stability. And actually we have two choices to choose between: to take the sampling, to make sampling tissue by open thoracotomy or by transvenous biopsy. Anybody who wants to deal with the question, what's to choose? And it's interesting to listen from the faculty. What would you do in this case?
Yeah, I think that I would say probably you have one more little arrow, which it's not necessarily an open thoracotomy. It would just be a mediastinoscopy or some sort of thoracoscopic sampling procedure.
It's actually, yeah, okay, I agree with you.
I mean, if it were to be a sarcoma, wouldn't it invade the RCA? This kind of floating artery sign there, with the RCA being so spared, I think that's relatively a good indicator that this is one sort of a lymphoma, diffuse large B cell even. So I would be thinking more in the lung of lymphoma. I don't know if PET is necessarily the way to go before anything else, and take some pericardial fluid sample, but still you need the tissue sample, right? I mean, I don't know. I would go more for that. I mean, if it's not vascularized, I mean, because that's the main thing you could get into trouble, would be transvenous biopsy.
So what you provide, Professor Carver, is transvenous biopsy?
Yes, so
okay.
It's Joe. I think that you need tissue, and I'm not sure that tissue adequate for characterization, especially if it's a lymphoma, or even to do markers if it turns out to be non-small cell lung cancer, which I don't think it is. I think that transvenous biopsy is not a good option, and that unfortunately that you need a good bit of tissue, and I think thoracotomy is the route.
Okay. Will anybody proceed without sampling, only empirical therapy? by anthracyclines or by other any means?
No, you have to know what you're treating.
No.
I agree.
So, okay. So there is consensus that we have to do some sampling, or probably by thoracotomy or mediastinoscopy. So what was attempted? Sorry, our surgeons attempted to do mediastinoscopy, but it was very difficult technically, and very quickly they moved to open thoracotomy. And it was very interesting that the two very experienced surgeons, when they did the open thoracotomy and palpated the tissue of this SOR, and they were quite assured. They concluded that we are dealing here with sarcoma. So it's happening on Friday morning. It's before Shabbat, so it's holiday in Israel. So we went on our holiday with knowing that the patient has sarcoma, and we're waiting for biopsy sample to prepare her for anthracycline treatment. It was the issue on Saturday. The patient got a little bit killed, like after open thoracotomy. She was in intensive care unit of surgeons. And on Sunday, the patient felt good. She was okay. And this is the histology. It was done the same day. And what we see here, we see that humor is composed of discursive large central-like cells with apoptosis and mitosis. You see it here with CD20 positivity within tumor cells and high MIB1 labeling index in the tumor and nuclear MEM1 expression. So actually we're dealing with diffuse large B-cell lymphoma.
Didn't someone say that?
Yes, I remember. Someone from Philadelphia.
No, you're Herman from Mayo.
Okay. Thank you. So actually,
so I assume the CD20 positivity is very confirmatory for a lymphoma cell. Is that correct?
Yes. And another imaging sign that was mentioned by Joe about sparing of right coronary artery or some sparing of vascular tissue is very characteristic of lymphoma.
Yeah, again, you're from Mayo. It's the floating artery sign.
I'm sorry. You have a nice voice, of Joe, you know.
I could be a comedian. Could imitate people.
So our radiology guys were very happy because it was their diagnosis. Because surgeons were very sure for 100% that we're dealing with sarcoma, and radiology guys were sure that we're dealing with lymphoma. And so radiologists win in this situation. So it was, we here present some imaging features of lymphoma versus sarcoma. Location, lymphoma is more from the right side of the heart versus sarcoma, which is the left heart. It's more homogeneous, and sarcoma with necrosis hemorrhages. About enhancement after contrast administration, lymphoma is less vascularized and poor vascularized actually than sarcoma with marked vascularization. And the main issue is respect borders, lymphoma respect borders when sarcoma invades in the borders. So actually we are dealing with primary cardiac lymphoma and non-Hodgkin lymphoma, which presented as cardiac disease, especially the bulk of the tumor is intrapericardial. It's only 1% of primary cardiac tumors and only 0.5% of extranodal lymphoma. So it's very, very rare disease. And it's more common in the immunocompromised. And one of the things we did, but our patient was incompetent according to available things. One of the reviews I found, it was a review of Adam Petrich from Cancer in 2011. They are talking about 166 articles reporting about 200 unique cases, but you see the time span is from 49 to 2009. It's more than 60 years. So it's very rare disease with male-female ratio about 2 with median age 63. I remember that our patient is about 63 years too. And 92% of them had either the right atrium or right ventricular involvement. And most common type was diffuse large B-cell lymphoma with 113 reports. Back to our patient, actually she received, right now she finished the courses of RCHOP, 6 courses of RCHOP. She feels much better. And you see this is a follow-up echo. In this place we had obliteration, actually the cavity, and now see normal right ventricular cavity. It's a long axis view, parallel long axis view, inflow view of right ventricle, and you see that there is no tumor bulk as was previously. It's the right atrium and right ventricle. It's in zoom. Maybe some involvement here, but it's for sure. We did the MRI after all, and by MRI there was no remnants of lymphoma, which is nothing. MRI was pretty normal. So if we summarize, we're dealing here with the primary lymphoma of the heart, diffuse B-cell lymphoma, that was successfully treated by accepted regimen of CHOP, and right now the patient on her holiday. What we want to explain that the presentation was quite typical in terms of dyspnea. You see that 64% of the patient who present with dyspnea, and pericardial effusion, as is what in our cases, in more than 2/3 of the patients. And about 20% could present with even tamponade. So it's dangerous disease. We have results of the therapeutic management, and you see that the patient that received chemotherapy had much better survival rate than patient that did not receive. On the right side, you see the all patient survival curve by Kaplan-Meier, and it's 128% patients, with median survival about 12 months. Prognosis is much better if the patient does not have no extracardiac disease. With extracardiac disease, prognosis worse. Immunocompetent patients survive more than immunocompromised. With LV involvement, when there is left ventricular involvement, prognosis is worse. And if the patient presents or develops arrhythmias, with arrhythmia, the prognosis may be as well not so beautiful. So only 7% of these patients had left side involvement in the absence of right side involvement. The common immune structures, they are intraarterial septum and superior vena cava. In our case, it was superior vena cava. And most common subtype is large B-cell lymphoma. Professor Carver mentioned about LDH values, high LDH values, and it was one of the keys to look if it was lymphoma. And you see that in 66 reports, actually, it was more than 22%, with a mean of 770. And most common cause of death in these cases was heart failure. It was followed by sepsis or other severe infection. We looked very carefully about embolic phenomena because from this huge SOL, actually developed. It didn't happen in our case, but we're looking very carefully for this. And it's the end. Thank you for your attention.
Yeah, that's a pretty amazing case. I think that was the best possible diagnosis from your biopsy. Everything else would have been, you're done. But that's amazing. So she's done okay, or how's she done?
Yes, She's still okay. She's without her hair, but hair will regrow, Everything else is okay with her. She returned back to her everyday activities, and I follow her by on 1 month basis. Every month I saw her, and we're doing followed by echo examination, and everything's okay until now. Hopefully, she will be okay.
This is a great case. I a couple other things that first, they generally respond after the 1 or 2 doses of chemotherapy very dramatically. So that's characteristic. And the other thing is that I've seen a couple of people, not only intracardiac but surrounding, who we've gotten asked to see to put in a pacemaker or to fix a PFO or something because of associated problems due to the mass effect. And the best thing to do is just to support people and not put devices in or go crazy, because they generally, as I said, respond to chemotherapy and those problems disappear.
Great, Kate. This is Arthi Patel, one of the cardiology fellows. I had a couple of questions. First, you had mentioned that an MRI was performed after initiation of chemotherapy. Was there anything done in, like an MRI done initially? I'm just interested in maybe some of the tissue characteristics that might have been present on MRI.
Okay, it's a good question. And actually, we're pretty sorry that we had no possibility to do MRI before. One thing was the relative instability of the patient, and then another, it wasn't available immediately. In my place, MRI is available only once a week for 2 or 3 cases, and we had no chance to wait for the MRI. And because of this, MRI was only follow-up. You're right about tissue characterization issues of MRI. And recently in one of the subjournals of JACC appeared a great article about MRI tissue characterization. So you're absolutely right. Unfortunately, in this case, we do not have initial MRI, we have only follow-up MRI. Thank you for this.
Interestingly, I'm seeing a patient here for cardiology consult from the cancer center here who has a non-small cell, who presents with a right, looks like ventricular and atrial mass. She's been receiving chemotherapy, and her tumor has responded pretty well. However, this mass, it was noted incidentally on a CT scan, and she's had it since she, as we look back, since she first was diagnosed with the cancer therapy, but the mass seems to be the same. So I'm, Dan, I know you had mentioned non-small cell lung cancer in regards to a left ventricular mass. I didn't know if you had any other insight.
Yeah, I mean, it's a real problem if that's the case, because, that's locally metastatic disease, and that'll be really hard to deal with. And it would be very significant risk for this patient to develop tamponade at some point, or even an SVC type syndrome. So it's interesting by imaging, but it's not very interesting for the patient.
No, absolutely. What do you think about it not responding at all to her current therapy, as her tumor, has significantly?
Yeah, that's just, I would say I would be surprised if it did respond.
Okay,
I just don't think typical treatment is not very effective for that. But I don't know, Georg, do you have a comment on that? I know you've seen a few cases along that line.
Yeah, so I think that I agree with everything you said, and that the key of the non-small cell lymphoma business is that the pericardium is almost always involved if there's stuff that's in the ventricle or in the atrium, and it usually is a dismal prognosis.
Thank you.
Yeah, I think that this the patient that Zaza presented, that floating artery sign, which was quite interesting, is, you just can't help but imagine that, this person would be at risk for an acute coronary syndrome at some point, but, I don't know what you can do about it other than, just make sure that you prevent any cardiac, primary prevention, basically aspirin and statin if appropriate and that sort of thing. But with tumor involvement surrounding the artery, then it would seem that as the tumor is being treated, that there could be a lot of vascular changes there. But I don't think we know about what's going to happen.
It's a great question. I have another patient, young guy with Merkel sarcoma. So Merkel cell cancer, and he presented with large pericardial effusion when tamponade. And when we did CT angiogram after treating his tamponade, it was fascinating to see his occluded right coronary artery. Tumor already occluded his right coronary artery without any signs of regional motion abnormality. And the patient was treated by etoposide and VP and cisplatin. And after 4 months on the follow-up CT, right coronary artery was open without any signs of damage. So you're right. And case by case, we have to treat the patient according to their risk profile. In this case, I was very scared about the patient not to develop actually ventricular infarction or any other thing. The guy is living. It's more than 1 year in my follow-up. He's feeling okay. He's getting Keytruda right now with some success, and his disease is under control.
Yeah, that's amazing.
It was the case I have consulted with you, if you remember, about doing autotransplantation.
Yeah. So
I'm happy we did not do it. Only.
Yeah, well, that's an absolutely heroic procedure. So, and then Georg, also, last webinar I showed your picture at the very end. I don't know if you have any follow-up as to the findings that you've gotten so far.
No, not so far. The patient is doing better. Her ejection fraction is improving. So we're still planning, because the other issue is with her that she said, well, we have this business. We produce fireworks, and 4th of July is sort of a big day for us in the year. And so she wanted to address this definitively after that. So she'll be back in July, and then we'll definitely we'll take her to the OR, and we'll have some tissue diagnosis. So expect July or August for an update.
That is crazy. So is Greg on the line?
He's not with us today.
Now, Artie, were you did you see the image from last time?
I don't think I did, but now I'm interested now.
Well, it was, as best I can describe, it was like a very large lipoma or fatty collection around the right ventricle, but it also looked like it went into there was sort of a little spot that went into the pericardial space. Is that correct, Georg?
Yeah, but we also did an RV-gram, and from that it really looked like a pseudoaneurysm from the RV, like this convoluted mass, how it appeared on cuts on the CT. It might be just this pseudoaneurysm. Now, this doesn't explain all this fat in the pericardium, because that's really, that was one of those aspects that really got us worried. But either way, I mean, it didn't seem like there was any acute change. It hasn't changed now. We re-imaged in the meantime. It hasn't changed in the interval. But yeah, really interesting case. So we'll prepare this maybe in a little bit more detail once we have the tissue diagnosis.
We'll look forward to an update at the end of the summer then.
Okay.
Well, fantastic presentation, Zaza. We so greatly appreciate it. And of course, I'll remind those that are on the call, they should definitely know that, we're having our annual international meeting in October in Nashville. It's always a good excuse for people to come to Nashville.
Yeah.
And then, so we're really excited about that. And then I think one other question would be, so each year we've kind of had a project that we've tried to do collectively. And 2 years ago it was a, best practice document, and we largely, we're working through the details of that, but certainly constructing it over the course of the year was an important step. And then last year we really focused on a fellowship document, which I think really turned out quite well. And then I guess my question would be, does anybody have a thought about what should be this year's ongoing project in terms of as a ICOS society project? Does anybody have any thoughts?
We could update bibliography on cardio-oncology to get us current in the literature.
You mean like establish a curriculum?
That would be good for the fellows to have some reference that would be easily obtainable for them.
That's interesting. Yeah, we could do that. I think that then we would have to have a place where we'd have to figure out a couple of items. First would be what characteristics of a publication would make it, what things would make it a curriculum worthy publication. So that would be one step. And then the second step is making sure that we posted it somewhere where people had access to it. And then the other part would be to make sure that we had a method of seeing if this was actually useful. See if people looked at it, or if they used that set of documents as a curriculum. So,
we could also do something on research directions and have some ideas about where we think research ought to be going, so that the fellows will have an idea of direction.
Do we have any other comments on all this?
Yes, I have one question. Does anybody have any information from our oncology fellows, from our oncology guys, if they're happy with our service, if they see that cardio-oncology is very helpful for them? Or in my place, at the beginning, it was very strange. It was a great deal of enthusiasm, and after that, it was some kind of decrease in the referrals, and right now we have another increase. So it's very interesting to do some kind of questionnaire for what are they looking in cardio-oncology service, how to figure it out. Do anybody has any experience in of this kind?
I think that there's a lot of interest in trying to define that. So if we summarized what you just said as, could we develop what makes up a good cardio-oncology practice? That's
some kind of survey,
Uh-huh. Yeah, so I'm sure there would be lots of opinions on that. So, all right, so we got one suggestion to develop a curriculum. We got another suggestion to try to, assess and define what a practice is. And then the other thing that I would toss out there is whether we could start developing a series of board-level type questions, that we could make sure the questions are good and, as examples of what the information that we think is important.
Yes, actually.
So does anybody have a strong feeling as to which direction we might want to go this year?
We'll meet in Nashville, I think, and we'll have a good time to discuss everything. But you feel that October is too late for the projects, yeah? You need them now?
Yeah, I mean, we can definitely do that. Whether I guess one option is to send out some sort of survey or poll to all the people that are considered members and see what kind of answers we get.
Okay, it's a good idea.
No comment from Joe there? Got nothing up there in Philadelphia? Are you guys still worrying about the Amtrak? I guess Joe's not on.
So I'm here. I still think that when I look and see one of the biggest problems that we have is that there's not a dedicated block to do cardio-oncology, and the questions are kind of an interesting way to ease into a curriculum, maybe the back door to creating a curriculum that every fellow ought to be exposed to. So I would tend to want to get this to become part of every cardiac fellowship, some piece of training. I mean, we did like an elaborate thing of this and that, but a detailed piece of what you should do and how to structure a block might be good, or a lecture series, maybe even a series of slides that we could present to training directors to say somebody ought to give these talks during the year.
Yeah, that'd be good. Then you kind of, in a way, you would put a circle around the curriculum, but also, what we think a practice may be.
Yeah, and then if there's nobody that can do it, and somebody volunteers, they may at least get educated to educate the fellows.
This is Arti again, one of the cardiology fellows. I was there, on the Society of Cardiac MR. Their website, when you're a member, is actually quite informative, and they have a lot of lectures and just content, basic learning. And I think that I think might be helpful for someone, fellows, even people who are currently practicing cardio-oncology, to help them sort of learn more about things that they're not so familiar with. And that might be a way to do it, make them available in some sort of online format, so that people are encouraged to join, and then they have access to these content sort of lectures, just moving along the same lines of creating slide sets.
Yeah, that's super. All right, well, maybe we'll develop a little survey thing and see what kind of answers we get from the various members, but I would probably suggest that maybe over the course of the summer, when we're lacking for things to do, we could, chime in about what would be a good lecture and try to develop some slide sets for different things.
We do have some new members to announce who have joined the society annually, who just joined this week and last week. There's Hatem Abrognia, who's from Summit, Pennsylvania, And then there's Yuri Alexandra, who's from Milano.
Man, wasn't there one from Brazil? And then
that was last month, and the month before we have others. We'll try to announce who the new members are when we get together here.
Perfect. All right. Well, fantastic presentation, Zaza, and we will.
Thank you. Thanks so much.
Thank you. I guess we have one in June on. Let's see, June 9th. Is that right? No, June 11th. Who's doing that one, Eric?
I'm not sure. I have to check the calendar. Of course, you know that annually we don't respect there being a February.
That's just in Tampa.
Exactly.
So this is Joe. I just make a plug for the new journal, Cardio Oncology is accepting patient manuscripts. If you're very wealthy, we would love to have you submit a manuscript.
Yeah, hopefully it's not required that people be wealthy, but at this moment it does seem that to be.
But we're actually open for business, and the reality is once we have 15 manuscripts, we can apply to get on PubMed.
Is this a journal you have to actually pay to submit manuscripts?
Yeah, you not only pay, you have to donate a body part.
What's the payment on that? Do you know?
Yeah, Dan, I'll tell you.
Oh, is this? Or Dan?
It's under active negotiation. We would love for you to submit your work, and if we can argue with the company to try to get that amount down, then we will do that.
It's $2,000 if your institution has a relationship with Biomed. It goes down to $1,500, and we have in the first year more than a handful of freebies that we're parsing out. So if you have a good manuscript, there's a reasonable chance that we can get it in for nothing.
Is there a way we can make this the official journal of
That's also been discussed.
Okay. See you at the meeting. We'll talk about it.
The person on the phone has been an advocate for that concept too, but the other people are not hot to tie in officially with anything yet. It's okay. I think ultimately it will come.
Well, the official list then extends into the membership, which then gives you subscribers who pay, and then you don't have to pay to submit a manuscript.
That would be.
So that's how we would do that if we can get everybody together to make that happen.
Yeah, Eric, we're on the same page.
We will keep trying. And I did look it up. Actually, it's Dr. Carver in June, so we look forward to hearing about Dr. Carver's experience.
Oh, okay.
That's what it says on the email.
Yeah, I think that, you know what, you have to check. I think that it was taken by somebody else, but let me know because I do have a couple of things that I could present.
Okay. We'll check on it.
Dan, I'll be near your home soon. I'll be in the mountains for 2 weeks if you want to come over.
Oh, man. That's quite a treat. All right. Well, thank you, guys.
Okay, thank you, everybody.
Thank you.
Take care. Bye-bye.
Bye-bye.
Zaza, toda.
Thank you. Toda.
Great, Zaza. That was terrific, man.
Thank you. Thank you very much. See you.